Congratulations to the Galactic Empire for the winner of the first part of the 7th Grand Annual CPC.
Everything that the Emperor had planned for years became a reality with the establishment of the Galactic Empire ruling with an iron fist.
The time has come. Execute Order 66.
We made the upper echelon proud by executing Order 66, removing the Jedi Knights out of the picture. This resulted to an ever-growing strength of the Imperial Army.
Not a single planet or army is a threat to us now, as we proudly unveil the Death Star, the Empire's pride and glory, the symbol of power to rule over those who want change and protection of the Emperor.
No rebels are a match to us. Any attack on us or our allies are futile. And we will retaliate with all our might to give justice to those who deserve it.
With our ever-growing might as we gather more allies to join the Empire and rule, we will continue to carry out the Emperor's desire for a single rule over the galaxy. We are the Galactic Empire!
My lord, Squad Leader Kilo reporting to you. A 48-year-old man residing in Zorzor, Lopa County, Liberia, came to the emergency department with behavioral changes. 28 days prior to admission, the patient developed pharyngitis and low-grade fever. He sought a private practitioner consult and was given on-recall medication. 1 week prior to admission, the patient complains of nausea and vomiting of previously ingested food. It was accompanied by 3 episodes of loose bowel movement, where he took 3 loperamide capsules, which brought him relief. 3 days prior to admission, the patient developed behavioral changes. He became agitated and refused to take baths. His persistent symptoms prompted consult. At the time of the admission, it was noted that he is febrile, double vision, slurred speech, and jerking of left arm. It was also noted that he is negative for all other diseases and that he is unresponsive to treatment. The review of systems revealed that he has loss of appetite, headache, difficulty in swallowing, and muscle pain. His past medical history was unremarkable. His personal and social history revealed that he is a smoker. He was an alcohol drinker, ingesting an average of 3 bottles of beer daily. His diet revealed that he prefers eating raw to slightly cooked bushmeat, mostly antelope. Familial history revealed for hypertension, cardiovascular diseases, pulmonary tuberculosis, cancer, and pernicious anemia.
Squad leader sa client signing in. At the ER, the patient is awake, anxious, disoriented, and in cardiorespiratory distress. He was febrile, hypertensive, tachycardic, and tachypneic. His BMI was overweight. In the musculoskeletal exam, a 4/5 muscle grade was noted in the lower extremities. There were no reported skin findings. In the neuro exam, the patient withdraws when light touch and pressure were applied on all extremities. CBC showed that the patient has eosinophilia and hyperproliferative hypochromic microcytic anemia. Coagulation studies showed prolonged APTT. Patient also has hyperglycemia, electrolyte abnormalities, elevated AST, LDH, and globulins. Lumbar tap was performed, and examination of the CSF showed increased CSF monocytes, increased protein, and presence of RBCs, but negative for malignant cells, negative for syphilis, no acid pass bacilli, fungal organisms, or bacterial organisms. For the ECG, there was sinus rhythm, normal axis, and a complete right bundle branch block. Lastly, radiologic studies were performed. Cervical neck X-ray was of poor quality. Chest X-ray showed dilated right pulmonary artery with pruning of peripheral vessels. While the lumbosacral X-ray was also remarkable. With this, we now proceed to our approach to diagnosis. We classified our approach into infectious and non-infectious origin. For the infectious origin, we are considering primary amoebic meningoencephalitis, rabies, and CJD. As for the non-infectious origin, we are considering acute disseminated encephalomyelitis.
My lord, Squad Leader McDermott reporting for Judy. We suspect the following diseases for the manifestations seen in the patient. Creutzfeldt cup disease. CJD is a rapidly progressive fatal and transmissible neurodegenerative disease due to accumulation of misfolded prion protein in the CNS. This may be ruled in due to the prominent behavioral changes which may be caused by consuming contaminated meat from African antelope, resulting in progressive deterioration of the patient's brain function and mobility, shown by double vision, slurred speech, jerking of left arm, weakness of the legs which extended to the hands, and progressed to inability to move the legs. However, CJDs are more common in the UK. The average incubation period is 14 months, with an average death age of 28 years. Thus, this disease was ruled out. Primary amoebic meningoencephalitis. PAM is a rare and severe disease caused by nuclear fallout. It causes inflammation and destruction of the brain and the linings of the brain, and is usually fatal. We consider this parasitic disease due to the behavioral changes, nausea and vomiting, loose bowel movement, double vision, jerking of left arm and headache supported by the labs, showing increased CSF, WBC, and protein. Nevertheless, the patient had low-grade fever, which should be high, no history of swimming in stagnant fresh water, or cranial nerve palsies, and CSF did not show leukocytosis with neutrophilic predominance and low glucose, but rather monocytosis and normal glucose as seen in the patient, and this ruled out the disease. Acute disseminated encephalomyelitis. ADEM is a neurological immune-mediated disorder in which widespread inflammation of the brain and spinal cord damages white matter. The disease has a slight male predominance, and in the patient we observe non-specific symptoms such as nausea, vomiting, fever, and headache. A viral infection of the upper respiratory tract may proceed with the development of these symptoms by 2 days to 4 weeks, as supported by the pharyngitis of low-grade fever 28 days prior to admission. Neurological symptoms that can develop include slurred speech and jerking of the left arm. May also cause weakness and pain, and there were behavioral changes seen. These symptoms are followed by mental status changes such as stupor and delirium. And all of this are strong ruling in factors. But this disease is more common in children than adults, and there's no noted hemiparesthesia, sensory deficits, and hemiplegia. The cranial nerves were also intact, thereby ruling this out. Viral encephalitis considering rabies. This is a rapidly progressive CNS infection due to lyssavirus, most commonly transmitted to humans from infected animal vectors via inoculation through bite. We ruled this in because the patient showed prodromal stage symptoms of pharyngitis, low-grade fever, nausea, and vomiting, and neurological syndrome including hydrophobia, slurred speech, and jerking of the left arm. Behavioral changes were also observed, including agitation, anxiety, and disorientation, with a history of preference for consuming raw or slightly cooked antelope usually. To further confirm this diagnosis, TFA must be done as this is the gold standard for rabies detection, while RT-PCR may be used as a confirmatory test. Nonetheless, we ruled in this disease. Our final diagnosis is viral encephalitis, strongly considered rabies.
Lord Vader, Lieutenant Colonel Lamis reporting for duty, sir. Rabies infection starts with the exposure of our patient with the saliva of a rabid animal. His preference for raw bushmeat, which is the most likely cause, with the transmission mainly occurring by the oral mucosa. The virus travels to the axons of the PNS in a retrograde fast axonal transport. During the incubation period, the virus replicates itself in the motor neurons and the spinal cord. It was also the time where he had symptoms of pharyngitis and fever. A week prior to admission, he complains of nausea, vomiting, and diarrhea. This could be explained by the prodromal period of the course of the infection, where the patient can show such inconclusive signs and symptoms. 3 days prior to admission, the patient has loss of appetite and hydrophobia. This could be explained by the virus being replicated in the salivary glands. The patient is now in the acute neurologic phase of the infection, confirmed by the CSF results and other systemic signs and symptoms, including the right bundle branch block, which could be caused by myocarditis associated with rabies. Encephalitis and rabies prefers the limbic system, which can explain the behavioral changes, the basal ganglia, which can explain the jerking movements, and the brainstem, causing slurred speech and double vision. Brainstem affectation can also cause the deterioration in the level of consciousness, leading to the patient's demise via respiratory arrest.
Lord Vader, Squad Leader Mesta reporting for duty. The initial management for a suspected rabies patient presenting in the ER is to do an initial assessment using the ABCDE approach. Once the patient has been stabilized, we need to monitor his vital signs and do a proper history-taking and physical examination. If the route of infection was through an animal bite, a thorough cleaning of all wounds and scratches need to be performed. Ideally, a post-exposure prophylaxis needs to be administered to all patients who have a known or likely exposure. A tetanus shot or antibiotic prophylaxis may be indicated. An aggressive approach to treatment is reasonable in patients who have a high likelihood for survival. However, palliative management is typically pursued in patients who are not likely to survive. In this case, the patient already presented with neurological manifestations in the ER is not expected to recover. Therefore, management should be focused on providing comfort to the patient through liberal use of sedatives and analgesics to alleviate suffering.
For the cause of death, the immediate cause of death is viral encephalitis, the antecedent cause of death is rabies infection, and the underlying cause of death is the ingestion of contaminated raw bushmeat. Lord Vader, we are ready for your final judgment.